Good morning, ladies and gentlemen. Welcome to the early in the morning session. This session is plenary number 4, how HPHs can contribute to health equity in communities. I'm the chair. I will chair this session, Takeo Nakayama from Kyoto University, and
I'm the co-chair of this session. I'm Shoti Cho from Taiwan Health and Sustainable Development Foundation, and also International Union for Health Promotion and Education.
Okay, thank you. And again, welcome to Japan and Hiroshima. And we believe that we had a very good time last night. How about it? So this session, we will discuss plenary number 4, explore the innovative aspect of community-based preventive services and healthcare delivery, as well as contributions of hospitals, healthcare, and social organizations to multi-sectorial action and collaboration with other sectors. Within this scope, the role of HPH health-promoting hospitals in removing barriers and promoting both physical and digital infrastructure for health and well-being in communities will also be highlighted. We will have 3 distinguished speakers from New Zealand and 2 from Japan. So I will chair the first 2 speakers. The first speaker is Professor Hiroshi Okada from Wakayama Prefecture Medical University. So, okay, Professor Okada, go on and make your presentation.
Good morning, everyone. My name is Hiroshi Okada. I'm a professor of the Wakayama Medical University School of Pharmacy. And my presentation title is Good Practice and Evidence on Innovative Aspects of Community-Based Preventive Services and Healthcare Delivery. My presentation, I'm currently a professor of the School of Pharmacy and conducting School of Clinical Researches in community pharmacies. But I worked at a community pharmacy for 10 years. What kind of image do you have of a community pharmacy? I worked in a community pharmacy 10 years. I felt that there was a great potential for the pharmacies to support to the people in community. So I have been conducting clinical research in community pharmacies in Japan. I'm born in Fukuoka. It's very famous for the ramen noodle, tonkotsu ramen noodle, and I studied in Kyoto. Today's chair is Takeo Nakayama. Dr. Takeo Nakayama is my supervisor in those days. Elderly population and 65 years old over is a Japan society that has been the most rapidly aging society in 20 years since 2000. Only 20 years ago, not a difference in the OECD countries, but now Japan is the top runner in the world. This is a positive aspect of the modern society, but it is also making it difficult to maintain the healthcare system. In Japan, which becomes the fastest aging society in only 20 years. In Japan, the role of community pharmacies are changed over the past 10 years. Japanese government began the community-based comprehensive care system in 2005. It is located medical and nursing care resources and linked and supplemented. Initially, pharmacists were not included in the system, firstly. However, when the pharmacists were added in 2015, about 10 years later, various services using the pharmacists began, such as the family pharmacy, pharmacist, pharmacy policy, and the health support pharmacy system now. In particular, the first home visit and health promotion activities in the community have become mandatory, has greatly expanded the work of the pharmacist beyond just medicine. When I worked for community pharmacy, I realized one thing. Some patients, especially diabetes or hypertension, they improved their HbA1c or blood pressure by themselves. Just I motivated them. And then they are very every time they say to me, say thank you every time. They really appreciate your support. I just motivated every time when they are visiting community pharmacy. So therefore, whether there is a difference in the, I did an intervention study, cluster randomized control trial in Japan. So I want to know there is a difference in the change in HbA1c between the pharmacists empowered their patient, and pharmacists just talk to medications as usual. There are two groups. And also, I make these types as a brochure for a patient. These I made it to these, and so I handed for my parents, my patients. Left is for the woman with diabetes. She loved the candy very much. At the top of it's a candy. She walked every day 30 minutes. But she said to me, it is difficult to lose weight. And so I asked her, how many candies each day? She said, 6 or 7. I calculated. The calories the same, 30 minutes walk. That is, I made that brochure for her. And also, our right side is man. He very loved the beer very much, and he really care about the calorie of beer, and I made it. That type of brief communication in community pharmacy, but some patients improved their lifestyle by themselves. I did this type of brochure for the intervention study, and the next slide shows the results. This very few brief intervention, but intervention group is a control, deducted HbA1c 0.7%. Unfortunately, control group also improved. I guess maybe they're motivated, signed informed consent form. And also I did another intervention study, cluster randomized control trial, and compass BP, blood pressure. Despite the very brief support of taking them, there was a 6 milligram mercury difference in the SBP. And also, I reported screening of the dementia in community pharmacy. Our community pharmacists sometimes find out the dementia person because their payers sometimes confuse the medication, and we are easy to find out their medication, dementia, and also their call to us to the pharmacy because so they're complaining about our so handed medicine. They said sometimes in the it is a wrong medicine or something, but so we don't we did the so correct thing, but they are so sometimes confused. That is we so realize maybe so their cognitive ability is lower and lower. And also so we are to taking the so dementia support system. The Japanese government have the so dementia support system being carried by the so government. There are no requirement of the become the supporter, and anyone can certified after taking a few hours training. The training involved learning about dementia and how to provide support. Program began in 2005, and to date, nowadays, more than 10 million people have been certified. Once certified as a dementia supporter, you are given an orange ring. This photo shows all the staff at my pharmacy after taking the dementia supporter training in 2015. And also we are preventing fatality of exercise in community pharmacy or sick day rule for people with diabetes. We did this type of intervention. And also, so we recent years lecture in the community healthcare have been given in Japanese pharmaceutical department. This is a scene from the one of my lecture. Students are using the materials they have made themselves to talk to patients about exercise as a part of the role play exercise to promote health in community pharmacies. We visited so many places in the community. As conclusion, in Japan, with the rapid progressing of the aging society, health promotion activities are being promoted at local pharmacies. Community pharmacies are located and accessible location between the people's home and the medical institution. It is good for support to the people's health and well-being in the community. Pharmacy education is also changing from the basic scientific research to the clinical practice for community health. This is the contact information. Thank you very much.
Thank you very much, Professor Okada. So we have 3 minutes for our questions. I will make 2 brief questions. You have experienced many barriers and obstacles to realize your project. How did you overcome them?
You mean that so difficulty in
yes,
the,
difficulties.
Yeah. Mm-hmm. And sometimes community pharmacies really hesitate to communicate with their patient because one of the reasons is physician.
Mm-hmm.
Sometimes physicians stop communicate. Some physicians don't like communicate with their patient, but once they know how important their role in the community pharmacist, they are motivated. They are also motivated,
mm-hmm.
and their motivation is from the say thank you from the patients. Mm-hmm. That is I explain about this type of message every time to them.
Mm-hmm. Okay, thank you very much. Okay, and the second one is I'm also interested in the change of the pharmacists who participated in this research. Is there any good change caused by this program among the pharmacists who participated in this research. They experienced many, many difficulties.
Yeah. So, committee pharmacist, participant. So you mean the participant in the committee pharmacy?
Yeah. Pharmacists themselves.
So there, one of the there. Sorry.
Okay. One of your paper is referring to the yarigai in pharmacists. Yarigai. Yeah. The positive attitude caused by these difficult project caused to among pharmacists participating in this research. They are motivated.
Yeah, so it's also the same things as also. So there, participant, the patient is also really sometimes they get a good result. That they said to pharmacists say thank you, or really appreciate your support, their support. That is they are really motivated, and also they can learn the new skill and knowledge from if they attend these types of intervention study, and because Japanese School of Pharmacy is focus on the basic science in those days. That is, they don't know the practical knowledge and skills. That is why I want to give these types of opportunity to them.
Okay, thank you very much. Such positive experiences felt by pharmacists will bring them go forward for the next step. Thank you very much.
Thank you very much.
And if okay, thank you. Okay, we have we will have a final discussion together for 15 minutes after three speakers lecture. So the second speaker is from New Zealand, Dr. Mihi Latimer. So go ahead, please.
Tēnā rā tātou katoa, ngō te whakatōhi me Ngāti Awahau, he mihi kia koutou ngā tangata whenua o te rohe nei kia tātou katoa. I'm from the Ngāti Awa and Whakatōhea iwi or tribal groups of New Zealand. I'm a director of a community-based Indigenous public health research consultancy, Taumata Associates, and my background is as a university-based researcher, working mainly in New Zealand but also in universities in the US. I've also had experience working in foreign affairs with the New Zealand Ministry of Foreign Affairs. My research interests are in health promotion and Indigenous-led approaches to addressing inequities and rebuilding localised communities. And I would really like to invite you, if you have an interest or are working in Indigenous people's health, then please come and introduce yourself. I'm really keen to make those connections. Now, I'm sure that we all know where New Zealand is, but when I was searching up a world map that showed where New Zealand was, I was a bit horrified to find that there was a website where people can post examples of world maps with New Zealand left off, and that there were 40,000 examples of these types of maps on the website. So I thought maybe I'd better just put this up to be on the safe side. And to give you an idea of the actual size of New Zealand, here we are, cozied up alongside Japan. But of course, Japan has a population of 125 million people, and in New Zealand, our population is 5 million. It was so sobering to come to this part of Japan, to Hiroshima, and during the opening ceremony to hear in person the words of Michiko Kodama. Her words also reminded me that inequities in health are contextual, and that in order to address them, we need to understand how they came to be and what are the factors that perpetuate those inequities. Māori are the Indigenous peoples of New Zealand. We make up 17% of the New Zealand population. At the time of first contact with the British in 1769, Joseph Banks, a scientific observer on the Endeavour ship, described Māori as vigorous a race as can be imagined. But all that changed with colonisation in the 1800s. Māori communities were decimated. And ongoing structural racism and colonialism continues to drive inequities in health outcomes and access to poor access to hospitals and health services. When we understand the basic causes of inequities, that can help us to map out the way forward. Now back to Albert. To paraphrase his words, we cannot solve problems with the same thinking that created them. To address Māori health inequities, that means adopting an anti-racist and an anti-colonial stance. What does that mean in practice? It's about enabling communities to transform themselves and working with them to remove systemic barriers that they face. For many years, Māori have fought to take control of health service provision for our own communities. The view is that we know what works for our own people and should be resourced to provide solutions that make sense for our communities, are grounded in our own worldviews and leverage the strengths of communities. It's important to also mention that these on-the-ground health promotion interventions are part of much wider action within the health field that's based on strong Māori activism around environmental issues and climate change, poverty and other determinants of health, and Māori language and cultural revitalisation. The activism is grounded in the work in the 1970s of communities that were really active and led interventions and work in all of these areas. That's from applying pressure for constitutional change through to seeking culturally and health responsive policy, right down to on-the-ground intervention in areas like circular economy, Māori co-housing, and many specific health issues. I want to talk now about a case study of the Te Kaha Medical Centre, a remote rural health service. It provides general practice services and a comprehensive community service. Because it's in a very isolated region, and here we can see where Te Kaha is on the map, they provide a lot of services that would normally be delivered by hospitals. So that's school nursing, public health nursing, 24-hour emergency response care, a whole range of services. And as well, they coordinate hospital practitioners coming into the region and delivering in areas like ear care, foot care, palliative care, lots of different areas. The centre serves an almost entirely Māori community of around 2,000 people, spread over a geographically isolated area of 100 kilometres. It's a region that has high deprivation, with many of the families living in poverty. For example, housing is a big issue. Some families live in tents and live in cow sheds. And as well, there's a very strong gang presence. The centre is one of 3 in the country that is designated by the government as a special doctor area, because it delivers to one of the most isolated and deprived communities in the country. And what that means is that because it's a special doctor area, services are provided for free. Due to the remote location, the experience of COVID-19 was different than in lots of other areas. And I'm going to use the centre's experience during the COVID pandemic, in which they achieved 98% full course vaccination coverage. And they achieved that months before any other New Zealand communities. and that includes the country's most wealthy and privileged communities. I'll highlight success factors that the centre continues to put into practice in its daily work and that I believe are transferable to other health promoting hospitals and health services. The first is an unconditional focus on equity. When the pandemic struck, Māori academics and health professionals established the National Māori Pandemic Group. The group called for COVID-19 national vaccination strategies that would make Māori a population priority because of Indigenous rights to health equity, socio-demographic risk factors, and evidence of a much higher risk to Māori of poor access to health services, the highest comorbidities in the country, and also mistrust of the health system. But the New Zealand government went with a general population strategy that prioritised older age, providing access to vaccines progressively starting at the oldest age band. What the effect of this was that essentially Māori were deprioritised because we have a youthful population structure, so that meant that a lower proportion of Māori had early access to the vaccine. The leadership of the Te Kaha Medical Centre knew that there wasn't a national plan for small, isolated rural communities like theirs, as the focus was, of course, on large population centres. They couldn't wait and took action themselves. Rather than wait for vaccinator training to come to their region, which would have taken a long time, a lot of waiting, they took their nurses to the closest city and joined their training, and community members were trained to take swabs. This meant that when they were able to access vaccinations or vaccines, that they were able to get started straight away. So instead of following the government's principles for initial rollout of the vaccination campaign by age band, they followed health promotion principles, prioritising those most at risk and experiencing the greatest inequities. They were prepared, they got in early, and they vaccinated the whole community. And up the top here we'll see members of the National Māori Pandemic Group. The second success factor is community leadership. The medical centre is a government service, so it's not part of the Māori community, but it is led by Māori clinicians. There are 11 personnel, mainly clinicians, and all but one of them are Māori, and all but two of them affiliate or are members of the local tribe. So they have an intergenerational connection with the tribe, a part of the community networks, and are trusted by local people. While you can train people to gain clinical skills, you can't train them to be a community insider. So there's no substitute for having Indigenous peoples, or if you're working with vulnerable communities, having those community members in your team. The COVID-19 response was led by the local tribe, Te Whānau a Apanui, working with the Te Kaha Medical Centre. The leadership group was a 5-member team called the Tribal Response Team. It included the medical centre's clinical director, who you'll see here in the photo, Dr. Rachel Moana Thompson, a visionary Māori health leader who is herself from the tribe. As an insider, Dr. Thompson was able to lead the iwi response from a medical perspective, and she has been the main source for a lot of the information that I'm presenting today. The third success factor, and the really important one, is to value community strengths. The strengths of communities are not always obvious to outsiders, and hospital and health service personnel in New Zealand have often taken a deficit view of Māori communities. The COVID-19 response tapped into Māori community networks, many of which have been in place for generations and are the natural mechanism for communication within the community. They tapped into Indigenous knowledge and values that guided processes and activities. Vaccinations and other activities were delivered in Māori settings, like on the marae, one of the marae is shown here in the picture. So the tribe itself is comprised of 13 sub-tribes, with each having their own geographical area, and a representative of each sub-tribe joined a group that provided an additional layer of support and connection to the community. Each sub-tribe looked after the people in their own region. The sub-tribes ran the vaccination rollout on the ground. They phoned people, they booked them in for vaccination appointments, and people would actually come to those appointments. Anyone who didn't have transport, they provided transport. And if anyone was missing, they knew how to track them down quickly. The gang community, some of the members are shown in the picture. They, of course, were very resistant to vaccination. Gangs are known for their involvement in profit-driven crime, especially drugs. Because of the relationships, a doctor, a nurse, and a few others were welcomed into the gang pad, so the gang members' base, with around 100 gang members, and they delivered vaccinations. It would have been impossible for this to happen with community networks, and there are not many doctors and nurses that would be prepared to go into gang pads. Individual groups covering specific key areas were also established by the tribal response team. For example, there was a group that covered food access and social issues, medical, schools, police, and local councils. And members of key organisations like the police and the council joined the meetings. The iwi also closed their borders into the area before the government ordered travel restrictions, and this was sanctioned by the local police and by the local council. The sub-tribe managed the borders on a roster system through the sub-tribes. Importantly, the community also had direct access to members of the National Māori Pandemic Group, which was comprised of Māori public health physicians, Māori immunologists and others. This meant that the community was able to stay ahead of the game, as they had direct access to the best available scientific evidence and policy information, as well as their own localised Indigenous knowledge. This allowed good public health decision-making that could be applied in an Indigenous way and make use of existing Māori community processes. For example, all activity by the community was communal, but at the same time, people were convinced to maintain their bubbles. In New Zealand, we use bubbles for your close contacts, your close social network who you don't need to mask or practice distancing with. Māori have traditionally lived communally in this way, so it was a natural way of operating, and systems were already in place that were Indigenous and localised to the physical environment. So as an example, hunters went out, they dropped meat off to marae, and there was a bubble that were responsible for processing the meat, and another bubble that was responsible for dropping it off around the community for free to families known to have the greatest need. And this was just a normal part of the traditional food distribution system that was already in place. To support the spiritual well-being and try to mitigate social isolation, spiritual support sessions and recitation of prayer were held online morning and evening, and Indigenous knowledge was also used in caring for the dead in a way which didn't rely on undertakers and embalming. The next success factor was about being pragmatic. There was also a need to be pragmatic and close your eyes to some of the things that were going on. So, for example, the tribe allowed people to purchase cigarettes and alcohol when they purchased their food, which was all organised by the tribe. And no effort was made to stop the drug dealers coming into the community, as they would routinely find a way to come in anyway, because Trying to get between people and their addictions would have caused major disruptions to the COVID response. And police turned a blind eye to hunting and fishing, which the government had restricted. They turned a blind eye because people in this community needed to do that in order to feed their families. The most pragmatic COVID response would have been to fund Māori communities to deliver the response themselves from the outset, but government didn't initially trust communities to do that, and they had to prove themselves. The Te Kaha Medical Centre continues to apply these success factors in its day-to-day practice. The approach taken by the centre is similar to what other Māori health providers have taken around the country, but the Te Kaha Medical Centre approach was very different from what hospitals and government-run health services did. The Te Kaha Medical Centre approach truly embodied what it is to be a health-promoting hospital and a health-promoting health service. And I'll just end with a bit of a memory. 30 years ago, I was listening to the New Zealand Public Radio, and my PhD supervisor, who is a Māori luminary, Professor Sir Mason Jury, was being interviewed, and he was asked by the interviewer, is it urgent to address Māori health inequities? His response was, yes, it's very urgent to address Māori health inequities, and it has been for the last 100 years. Kia ora.
Thank you very much, Dr. Mihi. Thank you. We know some name of Maori as indigenous people living in New Zealand, and the realization of the culturally appropriate healthcare is really a critical challenge for us. And you have shown some key factors. Thank you. And may I have I will make one question. Okay. To realize your goal, can only health professionals derived from Maori people do it?
So I think the important thing to note is that work has been going on for many, many years, led by people like my supervisor, Professor Mason Jury, who decades ago began with the very limited number of Māori health professionals at the time to set up systems to help and support Māori to train as clinicians. So that now, while Māori are very underrepresented still in the health workforce, we do have Māori health clinicians, and almost without exception, they in many ways dedicate themselves to Māori health and to reducing inequities. So we're very fortunate in that way because, we really realise and understand that for many other Indigenous communities and vulnerable populations, they have very few of their own health professionals. So what I would say to all of you is that it's really important that we all look around the table and see who's sitting there, but more importantly, look around the table and see who is missing. And that we support our Indigenous colleagues, we support community members to train and be successful in completing training to become clinicians. But in the meantime, if we don't have those people, we don't just say, oh, well, we can't get Indigenous or vulnerable population members of our team. What we do is that we get community people on board to guide us in our work so that our work can really become health-promoting hospitals and health services. But at the same time, in parallel, we nurture the development of Indigenous health professionals who will come and be at the table with us.
Okay. Thank you very much again. Thank you. Okay, I will sit. Chair. Okay.
Thank you, Mihi. Now we are moving to our third presentation in Plenary 4. The presenter would be Dr. Kazuya Yui. He is a managing director and a physician of the Kaomi branch of Saku Central Hospital. And that hospital and also Dr. Kazuya Yui are both famous of their agriculture medicine and community medicine. And the topic would be getting among farmers, reflecting on the roles of HPH from the perspective of rural health care in Japan. Dr. Yui, the floor is yours. Thank you.
Professor Cho, thank you very much. I'm Kazuya Yui from Saku Central Hospital in Japan. I am honored to have the opportunity to make a presentation about our hospital's activities at this prestigious conference. Our hospital, HPH, is known in the history of Japanese healthcare for promoting health in rural areas and contributing to the development of rural medicine. I will report on the history of these activities and explore the current challenges by urban and rural areas in Japan. Our hospital is located in Nagano Prefecture. Nagano in central Japan is known for its stunning mountains, outdoor activities like skiing, hiking, and hot springs. It also hosted in 1998 Winter Olympics. Saku Central Hospital is a medical group organization operated by Nagano Prefectural Federation of Agricultural Cooperatives for Health and Welfare, which is one of the agricultural cooperatives. HPH Group consists of 3 hospitals and dispatches doctors to frontline clinics in rural areas. This is the scenery of the southern part of Saku area, surrounded by mountains and abundant farmland. Dr. Toshikazu Wakatsuki became the director of HPH in 1946 and led for nearly 50 years. He is a pioneer in rural healthcare who contributed to medical activities in agricultural communication in Japan. In 1976, he received the Ramon Magsaysay Award for his achievements. This is a timeline of HPH's early development. Dr. Wakatsuki introduced various innovations in health promotion for impoverished rural areas. Outreach clinics combining medical care and health theater activities and hospital festival were key activities. HPH launched Japanese first total village health management program and contributed to training healthcare workers in rural areas. When Dr. Wakatsuki arrived from Tokyo to serve in rural Naga, he was shocked by the region's poverty. He treated many patients in the community who were enduring type, those who refrained from seeking medical care due to poverty, and unaware type, those who did not seek medical care because they lacked knowledge about their illness. Realizing that waiting at the hospital wouldn't improve the situation, Dr. Wakatsuki began outreach clinics soon after his arrival. At times, he attended to patients in the middle of fields. Dr. Wakatsuki established a theater group at the hospital and used it to promote health and hygiene knowledge during outreach clinics. He wrote many scripts for health promotion plays. This is a TV news program showing the activities of the outreach clinics team. They went to remote doctors' village to provide medical consultations. And after that, they transformed into actors to perform health promotion plays. Here they explain ascariasis in an easy-to-understand way through theater. At that time, there was a little entertainment. The residents also looked forward to the plays. David Warner is an internationally recognized health activist and author of Nothing About Us Without Us. He also emphasized the effectiveness of health education through plays. The INVAS care law states that those most in need of health care often have the least access to it. Social and economic disadvantages contribute to unequal healthcare availability, making it harder for vulnerable populations to receive adequate medical services. Health promotion activities that lack consideration for vulnerable groups risk widening health disparities. It is necessary to incorporate concepts like the vulnerable population approach or proportionate universalism. HPH initiatives have taken such ideas into account. Every May, thousands of people gather for a local festival called Komansai. In this occasion, we open up the hospital for residents for health promotion. It continues to be the most important event in a hospital. Based on the belief that prevention is better than treatment, Japan's first whole village health management program was initiated in Yachiho village in 1959 to detect latent disease early. In this initiative, all residents had their own health notebooks and register was used to record the result. This created a system for residents to actively engage in their health promotion. As a result, latent disease decreased, and after 10 years, per capita healthcare costs under the village's national health insurance significantly became lower. This diagram represents the organization setup for healthcare in Yachiho. Healthcare program required not only unilateral guidance from doctors and public health nurses, but also the cooperation of agricultural cooperatives and active participation from residents. This instills the belief that residents must take responsibility for their own health. The 1978 Alma-Ata Declaration under the slogan, Health for All, declared health a fundamental human right. The principles of primary health care are important. In Japan, shortly after World War II, health promotion activities in rural and remote areas were conducted equitably with an emphasis on intersectional collaboration and resident participation. This was 30 years before the Alma-Ata Declaration. HPH health promotion activities were an early form of primary health care that preceded this declaration. HPH has empowered several health volunteers, including hygiene instructors in Yachiho village. Nagano Prefecture is known for its high average life expectancy and low healthcare cost. There is one hypothesis that health volunteer activities enhance the region's social capital, contributed to this outcome. HPH has a 5-3-2 formula. 5 parts of our ability are devoted to care of inpatient, 3 parts to outpatient, and 2 parts to outside the hospital medical care and public health and hygiene service. With the slogan, "Getting among the farmers," we have aimed for equitable community health care in rural areas. Since the post-war period of rapid economic growth, Japan has experienced the contributed outflow of population from rural areas to major cities, leading to the decline of rural communities. The agricultural population is decreasing, and Japan's food self-sufficiency rate has dropped to a dangerous level. HPH's mission is to support the development of agricultural areas and promote the health of residents. And we are concerned about the current situation in rural areas. In large urban areas, the number of elderly people is increasing explosively, leading to the society with high mortality. The allocation of resources for medical care and lonely deaths are major issues. Lonely deaths are a phenomenon in Japan where elderly people do alone without anyone noticing for days or weeks. There are concerns about decline of rural farming communities. The progress of depopulation leads to social isolation among the elderly. Social epidemiology has clarified the relationship between social isolation and health. Although urban and rural areas have different structures, they face similar issue of social isolation. Cooperation between urban and rural area is required. The value of cooperatives such as cooperation, equity, and empowerment will become increasingly important for future health promotion. The health of all people is fundamental to the attainment of peace. Dr. Wakatsuki often wrote these words on a Japanese calligraphy board. And peace is fundamental to the health of all peoples. Thank you for your attention.
Thank you, Dr. Yui, for your wonderful presentation and for your hard works to promote rural health. I'm truly very touched. I would like to ask you that, as you mentioned, that along with the depopulation and the fewer, smaller population in this community, the need probably is even higher. However, how is the support and resources? Do you find it more difficult to recruit health professionals? And do you get higher, for example, policy or financial support from the government?
Thank you. I'm not good at English, so interpreter assist me.
すいません、英語の、支援、通訳支援を、利用させていただきます。
日本において、最初私が5対3対2って言った2の部分ですね。2の部分が予防活動とか、ヘルスプロモーションというところ、病院の外に出て行うヘルスプロモーションということなんですけど、そういうことに対していわゆる医療的な診療報酬というのがほとんどついてないのが現状で、今までは私たちの病院ではその自分たちの病院の理念としてその532の2の部分をしっかりやろうとしてやってきたわけなんですけれど、やっぱり本当に医療の運営が非常にですね厳しいということ、それからそういった費用にちゃんと診療報酬がついてないこと、それからまたその働き方改革みたいなものによってなかなかそういう今まで伝統的に行ってきた活動が職員の中でなかなか難しくなっているっていう現状があって、そういった活動を行うことにもですね政府のそういった支援がしっかりとつくことが願わしいかなというふうに思っております。
Thank you for the question. So in my presentation, I mentioned about the ratio of 5 to 3 to 2. And this last 2 accounts for our outreach actions, some things that we do outside of the hospitals. And this is where we do not receive reimbursement from the government. But this is also the portion that we have been trying to emphasize in our actions based on our philosophy. So, if we could receive more government support, financial support on this as funding, that would be great, because right now we are facing difficulties to continue this kind of operation. Another point is the current governmental policy to change the working habit in Japan. So because of this kind of improvement for the working conditions, the staff are facing difficulty finding time to do this kind of actions or operations. So if we could have more governmental support in this portion for the working condition too, that will be very nice too.
Yeah, thank you so much. And you can see the arrangement of the program. Plenary 4 is about what HPH can do for the communities, especially for the disadvantaged communities. And then the Plenary 5 will be about the upstream policy context to support your works, which is really very, very important, and we both will be there. So please stay until the end of this conference. So thank you so much, Professor Yui. Thank you.
Thank you very much.
So now we have a few minutes, 15 minutes for discussions, and we invite the three speakers to the stage, and we invite your questions and comments regarding this plenary session. Any question or comment from the floor? Please raise your hand and introduce yourself, your name, and your institution. If there is no hand, you are giving the privilege to the two chairs. So while you are still thinking of, oh, okay, Minnan, are you raising your hand? Minnan used to work in Tsuji, how do I say that? 医疗事业集团 Tsuji Foundation.
Medical Foundation.
Yeah.
Thanks
But now he is in the military center,
Okay.
for military-owned
Okay.
hospitals. Yeah.
Thanks for your inspiration speeches. Yeah, there's one thing that I don't know. There's a solution. Is that for sustainability? Yeah, because the aging society, the urbanization, and then also poor medical resources in a rural area. So we need support for health equity because we have so many RH programs with different kind of methods. But how do we persuade or motivate for the government or any kind of NGOs to support, to keep all these wonderful programs to be more sustainable, even better? So I think that we have a different solution in different country or different area, but I really think that it is very important for the support of the government. So because we have speakers from different countries, is there any comment on your opinion on the support from the government or from other NGOs?
Thank you. So what can we do to secure ongoing support from either government or NGOs for your efforts in these most deprived areas? Yeah.
Kia ora, I'll make a start on that because in New Zealand it's a very difficult situation at the moment because we're really reliant on political will to get the support that we need in order to fund equity-based interventions. And we have recently had a change of government, which moving to a more right-of-centre government, and they are vigorously cutting back funding for Māori interventions and in a lot of areas to do with Māori issues. And so it's very tricky, and there are no simple answers because you require that political will. And what is happening currently in Māori communities is a lot of political activism. So we've had peaceful protests. The next one is planned for the 19th of November. Where communities all around the country are mobilising and are going to take the issue to the steps of Parliament. At the same time, communities are continuing to use their own wide range of resources to continue the work, but it is really challenging, and I don't think from the New Zealand experience that we have simple answers other than to say that we will never give up. And Māori have formed their own political party to push the issues in Parliament. They're not part of this government, but they were part of the former coalition government. So I think, for us, it's a matter of maintaining hope, continuing to push, because it's just something we so strongly believe in. So I'm afraid that's probably not too helpful, but it's the situation in our country. Kia ora.
Yes, thank you. Other comments from the two other speakers?
いいですかね。大変難しい問題で、それを私が簡単に述べることはできないんですけれども、単純に言うとその社会保障費みたいなものをね、もう少しきちんと確保して医療従事者がちゃんと働けるような 場ですね。これはもうこの場にいる多くの医療従事者の方が思っていることかと思いますけど、非常に医療費抑制政策というのがきつくて、それ自体が問題である。ただその社会保障費どうするかっていう問題になると簡単ではないんで、ここで述べることはなかなか難しいということがあります。ただあと私はじゃあここで一回切って。
So, thank you for the question, and it is very difficult to give a simple answer to such a difficult and complicated issue. But one thing I would hope to have would be more social security funding, so that we can have better condition to provide health care. But right now, the policy is rather opposite. This kind of social welfare has been very contingent and reduced. And it's very difficult how we can solve this kind of issue.
でちょっと私の厚生連病院ということに引き付けて考えますと、医療をしっかり守るということと、やっぱり今の日本の農業がですね、食の安全保障という意味でも非常に厳しい状況で、その農業や医療っていうのはともに、社会的共通資本って、ソーシャルオーバーヘッドキャピタルとかソーシャルコモンキャピタルと言われるものですけど、それをどうやって守っていくのか。でそれはその地域の在り方、その都市の極端な一極集中と農村地方の過疎っていう問題をこの国がどう考えていくかってことと関連しているかなというふうには考えております。
And when it comes to individual hospital cases like us, I think what we should do is to protect our health care and keep going. And we are in a rural area where agriculture is the main industry. And this agriculture has been seen as a social overhead capital or social common capital as well as Medicare. So I think one of the issues that we have to think about is the centralization to the urbans versus our rural area being isolated. That's something we should be paying attention to.
Yeah, thank you. Yeah.
じゃあ翻訳してもらっていいですか？
Would you like to add?
僕は答えとかいいですか？じゃあすみません。So it's a difficult problem, and it is, yeah,
It's
almost.
beyond our control.
Yeah, but then,
But we need to think about how to better control it. That's health promotion. That's the reality, the real world. Wonderful, yeah. Yeah, Professor Osaka, Takio, would you like to add?
Okay, thank you.
You have a few words to say, right?
Okay, thank you very much. Let's share the difficulties among us. Okay, and traditionally, we healthcare researchers collaborating with the government, the Ministry of Health, Labor and Welfare. Traditionally, but recently I was making a relationship with Ministry of Trade and Industries, and their viewpoint are somewhat different. Health promotion is maybe preferred by Ministry of Trade and Industry. Yeah. This is a very, very positive direction. And their goal is to develop the new industries and making money, sustainability and monetize. So let's widen our viewpoint with the government.
Yeah.
This is one point.
Expand our focus to look for partnerships beyond health sector.
Right.
Yeah, that's one thing in the government. And also including the top politicians. They made the decision. But sometimes it's difficult due to their, the left wing, the right wing, those kind of things. So Amina mentioned the other thing is the NGOs. Sometimes we find some support from from NGOs. That's also important. And thank you for bringing political determinants of health to the table. That's very important.
Great
Yeah. And we need to learn how to engage politicians, and in addition, leveraging the power of data. Sometimes when the situation is very difficult, then we have to speak up. Then you hold data in your hand, show them the reality, the gap, and the benefits from your efforts. Yeah, and to get more support through, for example, media is also an important partner. Yeah. Further question? May I ask one? So between, okay, someone, okay, yes, please. I guess it's a colleague from, are you from Indonesia? Great.
Check. Thank you very much. My name is Rizka. I'm a physiotherapist from Indonesia, but currently I'm a PhD student in Kanazawa University, Japan. And my question is for Mihi Mathira, a doctor. And I have a question about what the specific challenge did you encounter in implementing community-led intervention in the indigenous rural community. And for Kazuya Yue, professor, my question is how to build a trust with the farmer and with the community or the hospital health promotion doctors and medical staff, others, because also in Indonesia, we have so many old farmers, but nowadays, no longer like young adults want to become a farmer. That it's important for us to build like a trust that, yeah, a farmer can be like a produce, so like a produce rice or something that it's really important for us like that. So how to make engage or trust with them. Thank you.
Thank you for the question. I think the biggest challenge that we have found in community-based interventions is the deficit-based attitude that funders and hospitals and health services bring with them when they come to work with communities. So a lack of appreciation of the critical value of the strengths within communities. And so what that then leads to is that there's a lack of willingness to believe that communities can lead their own health development and are the best positioned to do that. And so that has been an ongoing struggle that has been improved. So I guess it's really the greatest challenge for us is for funders and existing services to put the money on the table, but then to take their hand away. Kia ora.
Excuse me, was that a question for all presenters?
Yeah, I think it's okay. She also asked about the trust between doctors and farmers. But I think you saw that from the presentation. They dance and they play the show to entertain the community people. In this way, they get closer. And then, they work together.
Yes. 私たちはその何か農民のためにって言って for farmers っていうの together with farmers ってこう平たくやっぱり農家の方に接していって、まあ、そしてプレイシアター演劇をやるとか 講義をせずに演劇をせよっていうのは僕らの一つの手法なんですけれども、はい。
So in our case, we also tried to be close and be with the farmers, and we really tried to be friendly, make friends with farmers. And one of the things we always say is, do not give lectures to the farmers. Let's perform a play. Let's do a theater play instead of lectures.
Yeah, thank you. They used a very culturally sensitive way, yeah, to entertain the farmers and get closer. Thank you. So due to shortage of time now, we are at the final stage of this session. I'm inviting each of the panelists to give you the take-home message, each one no longer than 30 seconds. Yes, please.
So my take-home message is community pharmacy and pharmacists are a few remaining resources that can be utilized in aging society. And I'm very happy if you could use community pharmacy as a place for the health promotion.
Thank you.
I think the main message that I'd like to communicate is that we need to listen to our communities, we need to value what they have to say, and that communities know what their needs are and they know what will work for them in their own unique contexts. And we need to listen to that and be willing to hand power over.
私が述べたことは、その戦後の農村、貧しい農村の話ではなくて、今この日本社会がですね、格差と貧困がこれだけ極まっている中で、現代的な問題だと思っていて、その中でプライマリーヘルスケアとか、そのヘルスプロモーションのとても大切ななんていうかな、核になる話をしたつもりです。よろしくお願いします。
So I think the stories or the issues that we are facing is not only limited to the rural area of post-war Japan. I think it is the modern age issue of health gap. So that is something that all of us in primary care needs to think about. Thank you.
Okay, I'm very happy to be here and to share the difficulties and share the visions are very important. Let's go forward together. Thank you very much.
Thank you so much. And me too, it's a privilege and honor. And I think we realize that health professionals and community members, we work together, but we are like sheep in the jungle, and we need to work together to deal with the wolves in the jungle to make sure the sustainability of health promotion and health equity. So thank you for being here. Now we may call it a plenary session. And now thank you so much for your participation and input, and let's enjoy the rest of the conference. Thank you.
Thank you.
Thank you for the great presentations and input. Thank you.
Take a photo.
Oh, yes, yes.